I'm Dr. Sekineta. I'm one of the nephrologists at Scarborough General, and today I'm going to be talking about differences in kidney disease by ethnicity and country of birth in Scarborough. So there'll be 4 points that I'm going to talk about. Let me move this out of the way. The first point is 4 points I'll discuss during this talk. I'm going to talk about Scarborough and try to show that it's a place where diversity meets kidney disease. I'm then going to talk about the Scarborough Microcosm project, a research project that I've been engaged in for the last 4 or 5 years. That's nearing fruition. And it's aimed at answering the questions, who is getting kidney disease in Scarborough and why? And then I'm going to discuss, for the third point, disparities in healthcare, what they are and why look at them in Canada. And then I'll finish up with steps to resolving disparities, steps moving towards equity, how to level the risk. So 23% of Canadians were born abroad. That's current, that's changing, it's going to increase. We already have the largest immigrant population in the G7. About 250,000 people are welcomed into Canada every year, and that's projected to double by 2025. So that proportion of 23% will certainly increase. And as it is here in Toronto, 46% of residents were born abroad, and it's home currently to about half of all Black, South Asian, and Chinese Canadians. Now, these immigrants to Toronto are primarily economic immigrants, by which I mean they provide energy, expertise, and skills to Canada's economy. They are essential to the growth and well-being of our economy. And traditionally, most of the newcomers will have gone to the 3 largest cities, Toronto, Montreal, and Vancouver. Toronto already, as we mentioned, comprises about 46% of immigrants. Second would be Vancouver at 41%, Montreal about the national average of around 23%. Scarborough, a region within Toronto, is an especially poor place within Toronto, and as such it is especially diverse, and I'll show you here why. So the map on the left shows Scarborough to the right. It's the GTA in general, and Scarborough to the right, as you can see, is primarily in this mauve color, which is low income. So most of Scarborough is a low income region. The middle income is much smaller, and the high income is smaller yet. And the panel on the right shows that there's an inverse correlation between diversity and income. So when income is low, the panel on the left here, the pie on the left, diversity is high. You can see that non-whites in the low income area will comprise here about 69%. And as the income increases, diversity decreases to the point where in high income neighborhoods, only about 27% of people are non-white. So in Scarborough, it takes it to the next level. Scarborough already 73% of people are non-white, and that's compared to 51% of Toronto, which in turn is more than most of the rest of Canada. And then by immigration status, 57% were born abroad as opposed to 47% in Canada. And among the non-white people here, the top 10 groupings or subgroupings in Scarborough on the left and in Toronto on the right. And you can see there are some differences between Scarborough and Toronto. For example, people who are South Asian are roughly double the proportion of people in Scarborough than they are in Toronto. And similarly, people who are of Chinese descent are almost double what they are the rest of Toronto. And people who are Black, Filipino, are also more likely to be represented in Scarborough. And then similarly, by country of birth, top 10 countries of origin are different in Scarborough than they are in Toronto, either in terms of the actual countries or the the proportions. So for example, people born in China comprise 9.6% in Scarborough, but in the rest of Toronto, almost half that amount. People in the Philippines, more in Scarborough. People from Sri Lanka are about triple, actually more than triple what they are the rest of Toronto. And there's some countries in the top 10 of Scarborough that don't even make it into the top 10 of the rest of Toronto. For example, Trinidad, Pakistan, Bangladesh, and Guyana. So Scarborough's ethnic and immigrant makeup is different from the rest of Toronto, and it's very varied. Scarborough is also a kidney disease hotspot. Here is a slide from the Ontario Renal Network in 2016, where they were surveying all the renal programs province-wide. At the time, we were called the Scarborough and Rouge. That's where that arrow is pointing to. And you can see that at that time, we were projected, and we've since exceeded those projections. We were projected as of 2017 to have the largest dialysis population in the province, and projected to have this increase to even higher and to remain the highest in the province by 2027. So what is a CKD hotspot? CKD hotspots are countries, regions, or communities, or ethnicities with higher than average incidence of CKD. And they arise where there's an increase in the traditional, by which traditional or non-traditional risk factors for progressive CKD. So the traditional risk factors, we all know, I'm preaching to the choir, but diabetes is the #1 cause of kidney disease. High blood pressure is another cause and risk factor for kidney disease. Heart disease is a third one. And each of those, if they're not well controlled, would also pose risk factors for progressive kidney disease. And then there are some non-traditional risk factors that put people in certain regions at risk for qualifying as hotspots. Here is, I'm trying to move this. Oh, good. So here's a map of the world showing some hotspots in the US, African Americans. So this is using the definition of an ethnicity as a hotspot. African Americans have APOL1 gene variants that result in them being a hotspot in the States. In Middle America, in Central America rather, there's a so-called Mesoamerican nephropathy. It's of unknown cause, but they have very high rates of kidney disease there. And there's some others scattered around the world. Aristolochic ingestion, Chinese herb nephropathy, Balkan nephropathy. So these are examples of non-traditional risk factors that result in certain regions of the world qualifying as being hotspots. Oops. I'm going to talk a little bit more about that APOL1, which I showed you was considered a hotspot in the States. So APOL1 is a gene which protects or affects a person's susceptibility to trypanosomal infection or sleeping sickness. The person on the left here has 2 normal copies of APOL1, and that renders that person susceptible to infection with trypanosomal infection. If they have 1 or 2 variants of that gene, they are rendered protected against trypanosomal infection. And if they have 2 copies, not only are they protected against trypanosomal infection, they also develop kidney disease. So this would be an example of a gene variant that would have arisen presumably to protect against a local pressure, environmental pressure, which has the unfortunate side effect or additional effect that's unfortunate in this case of causing kidney disease. And that variant arose in West Africa, where trypanosomal infection or sleeping sickness is endemic, and would have been taken across the Atlantic in slave ships to the Caribbean and to the Americas in general. So Brazil, the Caribbean here, Grenada, Barbados, Jamaica, and to Blacks in the US. This gene is, the variants are almost exclusively found in Black people, and they are in these areas that are dark purple. The risk frequency is over 10%. The high risk is more than 10%, as opposed to the rest of the world where it's less than 1% or absent. So I think this, I hope, gets the message across that Scarborough is very unique. It has diversity and it has kidney disease aplenty. So the next point would be this SMS project, Scarborough Microcosm Project, as I called it. These are the results of a study that I'm about to submit. I hope to submit it in the next 2 weeks to hopefully to a CMASH. That's where I'm aiming to send it. And it's aimed at asking these questions. Who is getting progressive kidney disease in Scarborough and why? And it's a cohort study. There are 2 cohorts in it. The first is the so-called SMS dialysis cohort, where I looked at whether this dialysis population in Scarborough is a reflection of the population that it comes from. In other words, is it just a small, do you just zoom out or zoom in rather, Scarborough, and do you get the same proportions of ethnicity or country of birth just at a smaller scale? So put it a different way, are the ethnicities and birth countries in Scarborough reflected in its dialysis population? And so Scarborough data I could get from the Canada census, the 2016 Canada census. There are roughly 600,000 people in Scarborough with pretty good breakdown of the big groups. And we looked at our hemodialysis population. Primarily, there were approximately 1,600 of them around that same time. So from 2016 for the next 4 years, it's a period prevalence study. And we asked all 1,600 patients or family members, if they were not available, to find out whether they would provide us with their ethnicity or their birth country, or we would scour the charts to get that information. And we ended up with 1,368 out of that 1,600 for whom that information was available. This is busy, and this is really more for questions, but it shows, focused here on the top group of rows is ethnicity, and this is countries of birth. And all non-white ethnicities comprise about 80% of the dialysis cohort, whereas the white comprised 20%. And in Scarborough, the white were 26% and the non-whites 73%. So when you compare the frequency on dialysis with the frequency in Scarborough, we ended up with the dialysis prevalence ratio. So a ratio of 1 would be what would be an equal proportion between the 2 groups. In other words, it would just be a small version of the big one. It's what you might expect if everyone has equal risk for needing dialysis. And non-whites, as you can see here, had a slightly higher than expected dialysis prevalence ratio, 1.09, and this was significant. And the whites had lower than expected, 0.76, and this was significant. The differences were more striking when we were looking at immigrants versus non-immigrants. Immigrants comprise 85% of the dialysis cohort, and yet just under 60% of Scarborough, and that gave them a dialysis prevalence ratio of 1.44, considerably higher than 1, whereas people born in Canada comprised less than 15%, almost 15% of the dialysis cohort, and 42% in Scarborough. So their prevalence ratio was much lower than 1. It was 0.35. So these are going to be represented pictorially here, if I can get this to work. This is a representation of these same data pictorially, and these are not final. These are some of the things that have to be done before the paper is submitted. But the dialysis prevalence ratio here, you can see, is higher than 1. It's 1.44 for people who were born outside Canada. And for people who were born in Canada, it's 0.35. So the 1 would be the the even line that we might expect if there was equal representation. So immigrants much higher than non-immigrants. Whites slightly higher, as I said, at 1.09 versus versus whites at 0.75. And among the non-whites, who is it that's making the rates higher? The highest were Pacific Islanders at 1.6. South Asians and Blacks were at about 1.2 each. And East Asians were, as you'd expect. You can see the proportion here in Scarborough versus on dialysis versus in Scarborough is about the same. So the dialysis prevalence ratio was 1 for people who were East Asian. And then among the immigrant participants of the cohort, I just arbitrarily took the top 7 whose dialysis prevalence ratios were about 2 or higher. And in descending order, they are Jamaica at about 3 or just over 3. Italy, this one here is Trinidad and Tobago, Guyana, Sri Lanka, the Philippines, and Greece. So ethnically disparate countries. Obviously, the majority ethnic groups are different in each of these countries. And they all had rates that were double or more what you would expect. And on the low side, less than 1 were Bangladesh. And then around 1 were India and Pakistan. I point these out because these would be from the same ethnic group as people from Sri Lanka, but the ratios were considerably different. So this first portion of the study, the dialysis cohort portion, told me that the dialysis population is not just a small version of Scarborough, it's different. And this, of course, needs to be explained. We need to figure out why. And thinking about it, I thought there are 3 basic mechanisms that can increase dialysis rates. The first has to do with an increase in the number of people with incident kidney disease. And so this reflects increased risk for kidney disease in the community. So if in Scarborough there's more diabetes or more high blood pressure or more heart disease, then you would expect more early or incident CKD, regardless of the rate of progression, regardless of other factors. Just having more people at the start line would in time result in more people at the finish line, at the dialysis line. The second mechanism has to do with the rate of progression. So once you, for any given number of people at the start line, if more are going to progress to the end at a faster rate, then you would have more dialysis. And so those risk factors for that would include worse control of diabetes, worse control of blood pressure, worse control of heart disease. So when they come to our kidney clinic, we try and work with our colleagues to get their diabetes under control, their blood pressure under control, to see if this can delay the progression of their kidney disease. There are other factors such as the ApoL1 that I mentioned that result in progression of the kidney disease regardless of the cause of the incident kidney disease. So ApoL1 will cause more kidney disease to happen, whether it's because of HIV or FSGS or hypertension or diabetes. It has almost nothing to do with the initial cause of the disease. It has to do with the progression of the disease. And the third variable would be survival. If a person or a group of people die more on dialysis, during pre-dialysis, you won't see them on dialysis, and the opposite. So if they survive more, you will have more make it to dialysis. So survival is something which would affect dialysis rates. So the second portion of my study was aimed at trying to address these 3 mechanisms. And they all have to do with people who are in this pre-dialysis population, not the community, not on dialysis, but in this intermediate group. And I came up with a cohort of about 1,300 people. They were from the AIM study, which was a large 2,250 people prospective cohort study where they were followed for about 3 years. In the course of the study, every 6 months, they would have had things like at baseline, do they have diabetes? Do they have high blood pressure? Do they have heart disease? And then control. So every 6 months, we would figure out their A1C or measure their A1Cs, their blood pressures, their GFRs to see is their kidney disease progressing at a, we could compare rates of progression. We could also look at rates of progression of proteinuria as another face of kidney disease progression. So it was a pretty extensive data sets that we collected, and this was among 3 different sites in Toronto. 1,800 roughly were from Scarborough. So, and these were around 2010 to 2015. And so we, when we were designing this, had to go back and contact all 1,800 Scarborough-based people, if we could find them, if we could reach them, and ask them retrospectively, you know, where were they born, what was their ethnicity, and we tried to get some follow-up as of the time when we did this. Did they end up on dialysis? Again, a busy slide just to show, if in case there are questions, the non-whites were about 68% of this cohort. I couldn't compare this with Scarborough. I can only compare this in this study. I used as a reference white for ethnicity, and for immigrants, I used born in Canada, non-immigrants as the reference. So non-whites were 68% versus 32%. In terms of ethnicity, and then for immigrants, 82% versus just under 18%. Okay, so baseline prevalence of risk factors. I looked at diabetes. The left is ethnicity, the right would be country of birth. And you can see that compared with the reference, white, South Asians had much higher prevalence. That was significant at almost 3, and Pacific Islanders as well. And by country, Sri Lanka, the Philippines, Trinidad, Guyana, India, all had statistically higher rates of baseline diabetes. And remember, these are people who already have kidney disease. This is not general population. So people with kidney disease, more of them had diabetes if they were from these countries or these ethnicities. Because they all had kidney disease, it's not surprising perhaps that the blood pressure was everywhere. Everyone who has kidney disease pretty much, especially the early stages, or many people, have high blood pressure, and that was seen here. There was no difference between the different ethnic groups or countries of birth. And heart failure didn't see much in terms of ethnicity, but for country of birth, people from the UK, it's a large confidence interval, but it does not span 1. So people from the UK had higher rates of heart failure. Coronary artery disease was kind of interesting. People who were East Asian had small confidence intervals, and it was significant. They had lower rates of heart disease. And Blacks also not as low and not as narrow an confidence interval, but they had less. And by country, China, people who were born in China had, the confidence interval there is so small. They did not have the same rates of heart disease. They had less heart disease than people who were born in Canada. And then in terms of control of these risk factors, the arrows here indicate baseline. So when they entered the study, how were these variables compared to the reference? So by ethnicity, hemoglobin A1C was higher in Blacks than it was in whites. And by country of birth, it was higher in people born in Jamaica compared to born in Canada. And over the course of the 3-year study, the A1Cs did come down because this is solid, meaning it was statistically, it converged. It was statistically significant. So in other words, during the course of the 3 years, whether it was us or whoever, we were able to get the A1Cs down compared to whites. Not the case for people born in Jamaica. Their A1Cs were significantly higher and stayed higher. Systolic blood pressures were higher in Blacks and stayed up, dotted line. We were not able to get their blood pressures down, or we did not get their blood pressures down compared to the reference range. Same for diastolic, significantly higher baseline and did not go down. And then by country of birth, systolic, there's nothing different at baseline, but for diastolic, higher in people born in Jamaica, and again, did not come down in the 3 years. And then in terms of progression of kidney disease, the proteinuria rates were faster. They got worse more if people were South Asian. And by country of birth, they got worse more in people who were born in Jamaica and the Philippines and in Sri Lanka. So these three countries had a higher rates of progression of proteinuria than people born in Canada. And then here, maybe this is the money picture, GFR decline. Compared to whites, people who were Black had faster rates of decline, and this would be expected. If there's a higher rate of APOL1 high-risk variants, you would expect them to have a faster rate of decline regardless of the cause of the kidney disease. But what was unexpected was that the rates of decline were even faster for people who were South Asian. And this, I should add, was taking into account that is taking diabetes into account, so adjusting for diabetes, for high blood pressure, for A1C, for blood pressures, for heart disease, the presence of baseline heart disease, age, sex, FGF 23, pretty much everything that I could think of. The numbers were big enough that I was able to put a lot into the model. And people who were from South Asian had the fastest rates of decline. People who were East Asian had as well, but these were not perhaps clinically significant. As you can see, the slope is very similar to white and very different from the South Asian and the Blacks. And people who, by country, people who were born in India started out higher. Their initial GFR was higher. People who were in Guyana, their initial GFR was lower. But people in Guyana had a faster rate of decline compared to people born in Canada, as well as Sri Lanka. So these two here were significantly faster than born in Canada. And the people born in the UK, for some reason, didn't have a decline. It was different from people born in Canada in a good way. It actually resulted in them not progressing at all. So just to summarize, I won't go through all of these, I'll just highlight. Hemodialysis use in Scarborough was not equal across the board. It was higher if non-white, especially Middle Eastern. I didn't show that, I have to update my slides. Pacific Islander, Black, South Asian. Even more so if born abroad in these ethnically disparate countries, Jamaica, Trinidad, Guyana, Italy, Greece, Philippines, and Sri Lanka. Diabetes was more prevalent in people who had kidney disease, which is not to say that their kidney disease is because of diabetes. There's just more diabetes in the people who had kidney disease. Most of the time, we don't actually biopsy. So in other words, it's quite possible that some of these people had non-diabetic kidney disease as well as diabetes. And we don't know. This is something that might account for this. In other words, it looks like they have more diabetic kidney disease, but really they just have more diabetes. I don't know. But if they had diabetes, the control was worse if Black or born in Jamaica. And this has been reported elsewhere. The underlying means it's not reported, to my knowledge. Higher rates in immigrants from Italy and Greece, or people of A1C, people born in Jamaica. I haven't seen that in the literature. We didn't find differences in blood pressure, but we did find higher rates of poor control. That's well reported. The fact that it stayed that way even when they were receiving excellent care in a kidney clinic is interesting. The coronary artery disease being lower in people of East Asian descent has been reported, and it's variable for Blacks. They've also showed it to be lower, they showed it to be higher. I didn't see anything about it being lower in China. There are not too many studies that have compared a garden salad like Scarborough this way. So I don't know if this has been reported. Proteinuria rates were faster in South Asians. eGFR, this is what I really am most excited about, declined faster in people who are South Asian, more so than Black, which has been reported. East Asians faster than whites, but as I said, almost the same rate. And if you were born in Sri Lanka or Guyana, I'll get back to this, but this has not been reported. The year of immigration, when the immigrants came to Canada, did not affect any of the baseline, any of these findings. So if you just arrived or if you've been here for 70 years, it didn't affect these. And another key finding was that clearly aggregating, if we had aggregated by big groups like non-immigrants or versus immigrants or whites versus non-whites, we would have missed a lot of important heterogeneity within the groups. For example, whites, there are differences between Canadian-born whites and whites who were born in Italy or Greece. And as another example, aggregation by South Asian race would have missed differences between people born in Sri Lanka and Guyana. A lot of Guyanese, 40% of people from Guyana are South Asian. And this brings now something that I surmise, there's no evidence. This is, I wonder if what is going on here is a Lancet article looking at death rates from from kidney disease in India in 2001, 2010. And dark red means highest rates, which are 46 to 65 per 100,000. The lowest would be 9 to 29, so 2 to 4 times higher if it's red versus yellow. And you can see at the tip here at Tamil Nadu, they have rates that are 2 to 4 times higher than the north of India 20 odd years ago. And then about 10 years ago, you can see there's more red, but it's along the south still and along the east. And the thing that I find interesting is that these same regions are where a lot of South Asians were indentured to Guyana. So these green dots here are the ports of where they were taken from, where the British would take South Indian and East Indian. They were recruited from Eastern and Southern Indian villages, and they were taken for 5-year labor contracts. That was about 200 years ago. They must have missed their obviously this was didn't go according to plan, but they would have left from these 3 ports and traveled to Madagascar, South Africa, Fiji, and the Caribbean, including British Guyana. So this distribution to me is, it's certainly possible that the risk for kidney disease is different in different parts of India, and also in Sri Lanka, which is abuts Tamil Nadu. But I'm just surmising. So now I'm going to talk about disparities in healthcare, what they are, why look at them. So disparities, or also known as inequities, are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. And they are driven by social and economic inequities, the so-called social determinants of health. And these are the pillars of them. They have to do with income, neighborhood, education, food security, community, including policing and justice policy, and the healthcare system. And they are all impacted by racism and discrimination. Racism in this context, referring to the structures, policies, practices, and norms that assign value and determine opportunities simply based on the way people look or the color of their skin, that gives some an unfair advantage and others an unfair disadvantage and affects their health. And discrimination, the unequal treatment of members of various groups based on race, gender, social class, orientation, you name a difference, there may be discriminated based on those differences. Why talk about these in Canada? Well, they're here if sought. They're definitely here, despite having an excellent healthcare system that is supposed to be universally accessible to all. There are still significant differences in Canada, and these disparities are very costly, to the healthcare system, but of course to the individuals and their families and communities. Canada has pledged to address them. Canada in 2011 endorsed, as part of about 150 other countries in the World Conference on Social Determinants of Health. This was a WHO initiative. They endorsed this treaty that agreed to do the following. And basically, to summarize, the government was going to provide governance to tackle the root causes of health inequities. It was going to promote participation at the community level, prompting leaders or promoting leaders to make a difference. It was going to encourage the health sector, public health programs to reduce inequities. It was going to work on a global level with other countries to align priorities. And it was going to measure and analyze how well these policies and become accountable for the progress that was made in this regard. So Canada endorsed this 12 years ago. And so one of the things that came out of this was the what's called the health index tool, which I thought I could go to find out the answers to the first cog, like what at the top in Scarborough are the differences, for example, in diabetes, that might account for some people having more diabetes at this stage than others. And so this should be available at the public health level. But when I went to that health inequalities data tool, it's available online, this is what I found with regards to immigration. I found that the long-term immigrant health was, long-term immigrants had a relative ratio of 1.15. In other words, they had more diabetes. This is how it was broken down. Recent immigrant, long-term, non-immigrant, you can see there's not a big difference between them in terms of recent or long-term, which fits with what I found. But this doesn't discriminate. It doesn't provide sufficient resolution to answer the questions that I had. Are there in fact higher rates of diabetes in people who were born in Sri Lanka versus people who were born in the UK? It doesn't discriminate on this basis. It doesn't help me discriminate. The Canadian Institute for Health Information, it's a pretty authoritative body that's been working on equity, published about 8 years ago that the inequalities have either widened over time since this treaty was endorsed, or they've persisted. So Canada hasn't done a good job at closing the gap in healthcare. And the scope of these social determinants of health can sometimes be a little sneaky, can be a little surreptitious. So here's an example. So sickle cell disease affects Black people primarily. It's another monogenic disease. 80,000 people roughly in the States have it. Cystic fibrosis is a disease that's also monogenic that affects primarily white people. And you can see here the difference in terms of federal support, federal grants, philanthropic support, total support per person, that in every category, there are way more dollars that are spent on people with cystic fibrosis, the disease that affects people of Northern European descent, than sickle cell. For example, the private philanthropic support for CF is $152 million. It's $500,000 for sickle cell, same year, 2003. And the bottom line is that there's roughly $9 more for a person receiving to help someone with CF than there is for someone with sickle cell. So there's a biological difference to account for why Black people have more sickle cell or white people have more cystic fibrosis. But that biological difference is impacted by social determinants of health in terms of research, in terms of treatment, in terms of supports that are provided for the two different otherwise similar diseases. I don't know why my computer keeps... keeps freezing. So that's about disparities. Now I'm going to talk about towards equity. I think the first step towards achieving equity is to increase awareness, for us all to be aware of what is going on, both in terms of the literature and what's out there, but also in our practice. I got involved in the SMS project because on the dialysis unit, I became aware of differences in the people who were on dialysis versus when I went out into Scarborough, and I wondered if Scarborough was just a small version in the dialysis unit. So I was just curious about it. And after increasing awareness, I think there are a lot of levels at which a person can get involved. For example, advocacy in NGOs at the government level, education, medical education, research, the private sector, healthcare organization. Our hospital is very is becoming very involved in this area. Your own practice, working with the lay public, different areas. And I think the goal, as long as we can strive towards the goal, there's so many opportunities. And this would be the goal. This is the definition of health equity. It's when everybody, regardless of sex, gender, income, race, or other social demographic characteristics, has the fair opportunity to reach their optimal health. This is the definition of, I guess, what we ideally should be striving for, the definition of what Canada was striving for when they endorsed that Rio Declaration on Social Determinants of Health. So back to the CAI data, how can we begin to close the gap in health and where to go from here? And they came up with 3 concrete measures that they suggested to fix these inequalities that have either widened or persisted over time. In other words, to try and fix what is clearly broken. So they first came up with this idea of targeting specific populations. For example, Canadians with low income. If I were to expand this to the SMS study, it would be to target, for example, Blacks who have higher hemoglobin A1C, or people born in Sri Lanka who have more diabetes. And does that actually reflect more diabetic kidney disease? So targeting specific populations that are identified as being vulnerable was one of the recommendations from CAI, but they recognize that this has the potential to stigmatize the vulnerable groups and has to be done so in a sensitive manner. They suggested that more needs to be done to assess the economic costs and consequences of these inequalities, and to come up with cost-effective analyses of interventions, because if we can show that globally it's in all of our best interest to level the playing field when it comes to things like dialysis usage, it's going to affect all of us. Dialysis is approximately $100,000 per person per year. And of course, this comes from OHIP dollars. If that can be reduced, it's to everybody's benefit. The CAI also suggested that we identify, monitor, and report on inequalities at different levels of geography so that we can come up with priority areas, and to research exceptions to the norm. To me, this is hotspot. So if there are hotspots, if there are differences from the norm, we need to do research on those areas so that we can understand why some groups or some communities with otherwise similar economic or material conditions have lower levels of inequalities versus others. And they encouraged, as a final thing, in the designation or the design of interventions that are evidence-based to try and make differences and to disseminate the evidence across jurisdictions, to have discussions kind of like what we're having now. And now I would consider this perhaps community level, but to have them at the provincial level, at the national level, and to bring the evidence on trends in inequalities to the people, to the stakeholders who are affected by them, as well as health planners and community leaders like us, who are in a position to take action. And I'll just finish with a personal point of not contention, but so Toronto has these poor areas that flank the center corridor. This is where most of the Blacks in Toronto live. And I think that there's a lot of media, of course, about Black Lives Matter and disparities, for example, in COVID, susceptibility to COVID among Blacks. And there's a tendency sometimes to attribute this to racism, which undoubtedly occurs. Is it racism? Is it disparity? Or is it just differences? Remember, disparities are preventable differences. And I think keeping clear of the possible explanations for these differences is very important. I think keeping an open mind, first finding that there are differences, and then trying to find the reasons for the differences without jumping to without jumping to conclusions, I think is important. Here is a commentary in the CMAJ where they're saying that disparities between Black people and other groups with respect to medical conditions and risk factors are not explained by logical differences between races. So I take exception to this. So sickle cell anemia is a biological difference. APOL1 disease is a biological difference. How it's treated by the research community and the medical community, et cetera, is prone to racism, or at least to the social determinants of health. But there are biological differences. And I think statements like this can kind of close the door to the biological influence and lessons that we can learn about diseases. If we just focus, the pendulum has swung to the social determinants of health, which is very important, but I think both play a role and both need to be kept in mind when looking at health of populations. So I'm now done. These are my 4 take-home points related to the points I discussed. Scarborough is an ethno-culturally very diverse CKD hotspot. Significant differences exist in kidney disease and its risk factors among ethnic and immigrant groups here in Scarborough. These differences in kidney disease, here I'm going out on a limb, I think they're preventable. At least we should look at them further and see which of them are preventable and what is the reason for them. And as a result of them, me presuming that they're preventable, these are health disparities. We have to kind of go all the way to look at this. And then fourthly, on many levels and by many players, including us in this virtual room, more awareness and more action is needed to achieve health equity, not just in Scarborough, but elsewhere. And so with that, I'm able to take questions.
Before any question, can anybody hear me? Is Paul here? You hear me, Tabo?
Yes, I can hear you.
Tabo, I congratulate you and I thank you for doing this work out of your own time. Obviously, the office helps a lot, and I'm really proud of you. I always go out to say that we have a problem, but this is evidence to show people why we have a problem and how we can tackle it. And recently, I am talking to a major pharmaceutical company. They were talking about paying focus on diversity and equity. I think that this type of the evidence that we can go out there and show that we are actually demonstrating something, and then we get resources, whether from whatever sponsors or even the government, to try to get on to help us to solve this problem. I'm an immigrant. I think that a lot of us came here, we contribute to society, but at the same time, we bring certain, like you said, some burdens over here, and we need to tackle it. Otherwise, the health of the population will not be improved. So thank you again, Tabo. Good job. Well done. Anybody has questions, you can post it to Tabo or send it to him.
I see a question here. For those born in Canada of immigrant parents, are they at the same risk as those born and migrated to Canada? And secondly, is there a difference in mixed race individuals? I'm not sure. I haven't looked at that. And I'm not sure about the data from other sources. I don't know yet, but if there's a biological risk, my guess is that that would continue in second generation persons. So in other words, if somebody has an increased risk when their parents moved from West Africa, but they were born here, I think they too would be at risk for APOL1 nephropathy, just like their parents who were born in West Africa. Was there a difference between men and women from non-white? I'm not sure, maybe I'm falling behind. If someone can just ask questions, that might be easier, so I don't miss anybody. Oh, Paulette.
Hi, I was just wondering, Dr. Sakinada, great presentation. Really, really good. A lot of work you put into it. Just this Apple One gene or whatever it is. So what can be done to ensure that people who are at risk can be tested to make?
Well, it's funny you say so. Currently, it can't be tested for in Canada. Dr. Musi downtown, who's a transplant nephrologist, is trying to increase the uptake of renal transplants in Black people. They have traditionally much less live donor rates than other ethnicities. And obviously, if I have a brother who's on dialysis, and I was born in West Africa, I would want to know before I donate a kidney to my brother, I have the APOL1 high-risk variant, right? This would be an obvious thing to know. And he can't get that tested for. Him, a transplant surgeon downtown at a research center. It's not available. And that map of the world where I showed you the risk frequency for APOL1, it's blank for Canada because it's not known. So we don't have the ability as of now to test for it, even in a research center, which is, I think, shameful, right? Canada has had slavery for about 400 years. There are a lot of Black people in Canada who are at risk and have kidney disease, and yet we can't even assess for this risk. This would be an example of something that I think should be advocated for.
For sure.
Zara? Michelle James, sorry, I'm okay, so Michelle.
Yeah, thank you. Thanks, Dr. Sakinada. It was a fantastic presentation. One of the things that we're working on at the hospital is I'll just put my video on, is the collection of ethno-racial and socio-demographic data beyond what we currently would collect. And we were doing this a number of years ago, actually, at the Scarborough Hospital. We stopped for a while when we transitioned to EPIC, and now it's something that we are doing at all 3 sites. Currently, we're asking registration staff to collect this data in all 3 of our emergency departments. And the next step is to put it into the kiosks, the self-registration kiosks that we have, so that we would have all of this data and it would be integrated with EPIC. And I was just interested in your thoughts as to whether you think this would be valuable and any advice you have in terms of how we can make physicians aware of this, because the important thing is to use the data, not just collect it. And I'd be interested in your thoughts in how we could be successful.
Okay, so I thank you for the question. Can you see this screen? These are your data, right? Can you see the screen?
I see the take-home points.
Oh, I see. Oh, so I'm not sharing this one. I'm sorry. So your data, you had collected those data in eMERGE for over, I think it was about a year, and there are about 166,000 people roughly.
Right.
Provided information on safe things, should I say, like gender and what was the other one? Gender and date of birth. But I noticed a big drop off in terms of the number of people who responded to ethnicity, and an even bigger drop off in terms of country of birth, and an even bigger drop off in terms of year of immigration. In other words, what I saw in your data set is what I experienced. There were 1,800 people. Yeah. I only got 1,300 who responded. There's a challenge in getting that information. Those race-based and ethnic-based data, we have to be better, all of us, at getting those data and making people feel comfortable providing those data, trust us with giving, trust us with what we're going to do with those data. It's the drop-off in your eMERGE cohort was from 166,000 down to, I think it was 30,000. In other words, 130,000 people did not answer those questions, some of those questions. So I think you're on the right path, and I'm on the right path. We have to get these data. I think that's clear, but there are definitely some challenges as to how we get them, and we have to be better at it. And I don't have answers for that.
Yeah, absolutely. And we're working on that. We're going to do some education because what we found this actually in the COVID vaccine clinics when there was an attempt to collect sociodemographic data across the province, that the barrier actually wasn't in people feeling comfortable answering the questions. It was in people feeling comfortable, people answering the questions. It was the discomfort with asking the questions. So it was the people doing the surveys didn't feel comfortable asking those sensitive questions. So we do need to do some education to support that aspect of it. But I just want to, maybe we could circle back and have some more discussion about how we could really bring this to the awareness of our physicians so that they could start to incorporate this kind of data in their work and identify opportunities for improvement.
Yeah, I think this should be part of the initial screen at initial point of contact with every interaction with patients.
Yes.
Across disciplines. And I think it's so important. Thank you.
Thank you.
Zara?
Hi, a very interesting talk. I was just wondering, since it's, these renal disease has some gender component in which males and females have specific or differing disease trajectories and progressions. If there was any kind of sub-analysis in your data that addresses this and maybe splits the data of non-whites or white populations based on gender and allows that distinction maybe of populations that might be behaving differently, specifically in EGFR and urine creatinine.
Yeah, I didn't do that. I've seen that in a lot of similar studies, like epidemiologic studies, where they provide the data for males and for females separately. In some ways, I'm happy. The clinical epidemiologist I've been working with, I was happy that she didn't insist that I do that, because then the numbers would be split even more to smaller and smaller. Like, for example, there were only about 150 people who were Black in the pre-dialysis cohort, so that would make it we're doing the same analyses, but on half that amount of a small amount already. In other words, I would get smaller and smaller. So I think those need to be done when you have bigger numbers. I'm afraid that I might lose power, and some of the p-values would go away when I try to split the data in half. But I did include gender in all of the models for whatever it's worth. But I get your point. It's very important. Thank you. Ethel?
Well, that was a really excellent talk, and I think it really helps us to make more consideration to how ethnicity and origin of birth in our population have impact on the risk of chronic disease in general, in particular kidney disease. As of late, we've been sort of re-looking at improving our capacity within many of the programs across Scarborough Health Network, including in nephrology. And, one of the things that we struggle with is sort of risk stratifying all of the referrals that come to us. So I think your talk kind of helps practitioners to sort of incorporate this whole ethnicity and origin of birth into that risk stratification and helping us get better at that and really getting services to those that are most in need. With the Ontario Health teams as well, especially Scarborough Ontario Health teams, we've also identified chronic disease as a priority population, and obviously Scarborough population is filled with those types of patients. But from a health equity perspective, we were learning more and more about system integration and collaboration. So in your last point about the need for reducing the barriers to improve health equity, do you have a sense of how we could better leverage the integration throughout our Scarborough system to enable improved health equity?
Sorry, how we can better enable integration between who and who?
Like we're learning more about how to integrate services. And I'm just wondering, like, given all of your research, what would be, some maybe low-hanging fruit as to how we could leverage services to help reduce the barriers?
Quality
Yeah.
services. Yeah. So I think I agree with the CAIHI recommendations that by identifying or having identified high-risk groups, target measures can be brought about. So, for example, higher A1Cs in Blacks, I think, is something that requires a targeted intervention, whether that means involving industry, make sure they all have referrals to endocrinologists or something that, so once we've identified a group as at high risk, they have to be appropriately managed to try and reduce the risk. It's like if you're high risk for anything based on a screen, the point of it is to try to reduce that risk more. And so, I mean, we might say that this is just one study, it's not enough. And I would agree with that. But then, this needs to be done here. Similar work, I think, needs to be done elsewhere. Trillium has the second highest rate of kidney disease province-wide. And we should be networking, I think, with Trillium. Some of these data, it took me a long time, but, I don't think they necessarily have to take a long time. Once we are able to get similar data faster elsewhere, we can start to pool these findings. And if we find, so for example, people who are born in the Philippines, there are a lot that are serviced in Trillium. And if you find the same thing in Trillium, that there are a lot who have diabetes and that there are much higher rates of dialysis in Trillium, then I think that might increase the confidence to say, okay, here is an at-risk group. It's not just based on one study out of Scarborough. Once you've pulled enough and gained enough confidence, you can say this is an at-risk group and we need to treat them differently to reduce that risk. We don't treat them the same. It's a bit like blood pressure. You don't try to get a blood pressure 120/80 in someone who's 95 years old. You do that when so you treat people differently based on their risk. And I think that's how we can use the services, how we can integrate the services. Kim?
Hi, great discussion and great talk. I found it very interesting that, both where a person identified as in terms of their background versus also where they were born, that it didn't matter the time frame in terms of their immigration, that they still had the same risk factors. So that lends me to think that, there are those health disparities that still exist potentially. And kind of looking at the community that we're in Scarborough, that potentially, as you were saying, community outreach might be one of the factors in terms of health education to try to prevent progression for those at risk would be one potential area that we could potentially focus on. So I thought the discussion was great. One of the things that I was thinking of as we were talking about identifying as a certain background or race, I think in Scarborough we have a lot of communities and individuals that maybe potentially don't identify to a certain race or a certain culture, which I think sometimes there's lots of mixing in cultures. And I think sometimes that potentially may be a barrier in terms of how people identify themselves. So that may be something to think about in the future.
Yeah, I think this type of study is going to be tougher to do in 100 years because there's so much mixing and so much, like we're all kind of becoming more heterogeneous. So the lessons that I think we have to take what lessons we can now, like, for example, what if there is a increased risk of biological risk in people who are from the south of Asia? That would be more difficult to find when there's pooling and mixing of genes. So I agree with you. It will be more challenging to do this as time passes. Okay, I think that was all the questions.
Thank you, Tabo. I think this is a good talk to end the kidney month. It highlights our problem that we face and the challenge ahead of us. So I think that it's a perfectly good start to look at things as we go along in tackling our problems in Scarborough with kidney disease. And thanks again, Tabo.
Okay,
And
thank you.
thank you everybody for attending. Yeah.
Paul, thank you for your help. Paul was instrumental in, couldn't have got this done without Dr. Tam's help.
Thank you, Bob. Thank you.
Okay, bye.
Bye.